Dear Pure Urology FB Facebook friends, good evening one and all. Today program is actually not expected program. As you all know, our Urology Society of India National Conference is ahead. We are focusing on small things like instruments, lasers, like that. So I thought we will discuss about the urethroplasty instruments casually in the Pure Urology Forum. However, because of the busy schedule, not many seniors could participate in the discussion like yesterday, laser missions. Most of us will be focusing on flexible scope, laser missions, and nephroscope instrument. But urethroplasty is one surgery where we have to know certain small things, especially for the juniors, especially if your unit is not regularly doing urethroplasty surgery. So I thought in the afternoon, I will ask my close friend and senior, Dr. Ashish Pardeshi, who is from Pune, can you do the instruments? He said within 2 minutes, why not? I'm in the theater. I will take the instruments and explain with whatever the basic instruments available. So he immediately said, okay, I'm really thankful to him. Hi, Dr. Ashish Pardeshi.
Hello, what is sir? How are you? Wish you a very happy
Fine,
New Year.
fine. Thank you very much for accepting at a short notice. Actually, Dr. Ashish is supposed to give talk on difficult cases of urethroplasty next month because we are trying to avoid too many tight schedule before our national conference. So we are doing small conferences, but for some juniors, it is very big thing because which retractor to buy. This all you please explain, Dr. Ashish. I personally thank this program is a recorded program and a lot of audience will see about the urethroplasty instruments. Take your time. I am not, I do a lot of buccal urethroplasty, but I am not the expert to talk about that. Whatever the information you give, it will be useful for me also and my team also. So with this, I will introduce first Ashish. Before I introduce, I want to ask Ashish brief few questions. Where did you do your MBBS?
Sir, I did my MBBS from Bharati Vidyapit Medical College, Pune, from the University of Pune. Yes.
Okay. And MS from?
MS I did from KEM Hospital, Pune, and I did my DNB Urology from Jaslok Hospital, Bombay.
Okay. During your MS period and MCH period, I heard that you are also a very good urethroplasty surgeon from Harshavardhan, and many other people confessed that. And you do very nice dissection and you do a lot of cases in a day also. That is good. You are a young urologist who is upcoming with this new branch, new specific branch related to urology because hypospadias, fistulae, difficult urethroplasty, post-trauma urethroplasty is a separate subject now. Good that you have chosen interesting subject where a lot of hand skill is required. Who is your mentor during your training?
Luckily, when I was doing my MS, I was lucky enough to have a pediatric surgeon. I was in the pediatric surgery unit for about 11 months in my 3-year surgical residency. So Dr. Govind Datar was a pediatric surgeon who used to do a lot of hypospadias and extrophy bladder actually.
Very good, very good.
Luckily, Dr. Sanjay Kulkarni was also there. He was attached to the same hospital. So with these people, I got an early exposure for reconstructive urology in my early
during
days.
Your MS only. During your MS only.
Yes.
Oh, that is nice. That is in Pune KEM.
Yeah, Pune KEM.
Oh, your native place is also KEM. Sorry, Pune.
My native place is Pune. Born and brought up in Pune.
Oh, fantastic. And your MCH, during MCH, who was your boss, DNB?
During MCH, Dr. Percy Chibbar was there. Dr. Raina was there.
Oh, fantastic. Chibbar sir is a very well-known surgeon.
Yes,
and apparently he is also very good skilled surgeon, not only in endourology, but also.
Yes.
And very patient teacher also, common sense and very Very, very patient teacher.
Very true. Then I went to Serbia, actually, Belgrade, to Dr. Professor Rados Jinovic,
Okay, okay,
where I
okay.
learned penile surgery, complex hypospadias and penile implants.
He is famous for which surgery? Hypospadias or urethroplasty?
He is famous for hypospadias, for penile implants, for transgender surgery. All these things he does very well.
Okay. So how many months you stayed there?
I stayed about 2.5 months.
Oh, fantastic. That is a fellowship program?
Yes, that's a fellowship program.
Oh, fantastic. After that, you returned and started practice in Pune now?
Yes, I have started practice in Pune.
Now, how long you are into private practice in Pune?
I am into private practice since 2011.
Okay. Oh, quite good period. Very good.
Yes. Yeah, I had a 10-bedded hospital right now. And now I'm upgrading it to a 25-bedded pure urology, nephrology, and reconstructive urology center.
Oh, very good. So you are soon coming up with a 25-bedded hospital.
Yes.
So with this introduction, today we are discussing on urethroplasty instruments. This is a short notice program on a specific subject, urethroplasty instrument. Once again, I thank Dr. Ashish for accepting this. He is the director. His hospital name is Kidney and Urology Super Speciality Clinic Pune, who is going to be upgraded sooner. And it is Center for Advanced Penile and Urethral Reconstructive Surgery. His area of interest is this. And consultant urologist at Jahangir Hospitals Pune, Jeslok Hospital Mumbai, HN Reliance Hospital Mumbai, inter-college member of Royal College of Surgeons exam. Also he did in part 1 and part 2, and he has published many journals. With this introduction, we will hand over the program to Dr. Ashish. Ashish, I may be interrupting in between with my limited knowledge. Don't mind.
No problem. You're always welcome, sir. It is an honor for me.
Over to you from the beginning, from the position padding where you put pads like that. You take the journey towards the end of the surgery up to the skin suturing and dressing, please.
Yes. Thank you very much, sir.
Thank you. Thank you very much.
Hello, friends. Thank you, sir, for Dr. Vati, for the opportunity to present this very, very practical aspect of reconstructive urology, that is patient preparation and instrumentation in urethroplasty. Urethroplasty is a reconstructive surgery where the surgeon needs to be well planned before, because sometimes the steps of surgery can be unasked for or unpredictable. So everything has to be ready before we undergo urethroplasty. Let me broadly classify urethroplasty as into two basic groups. One is traumatic urethral strictures and non-traumatic urethral strictures, because the instrumentation, patient preparation, everything else is different for these two kinds of procedures. If we talk about non-traumatic strictures, what we do is augmentation urethroplasty. We do not do transection in non-traumatic strictures. Therefore, we use grafts or flaps or do stage surgery in non-traumatic strictures. In traumatic strictures, most of the time, we concentrate on anastomotic urethroplasty. So this is a broader classification we need to understand before we plan any kind of urethroplasty. Let us start with non-traumatic strictures, where we are using a buccal mucosa graft for a patient of, say, a bulbar stricture. After the patient has been evaluated by your basic investigations like sonography, your retrograde uretrogram, and cystoscopy in some times, and the patient is on the table, we need to plan the surgery properly. What I do is, before the surgery is planned, we give beta blocker like atenolol one night prior to most of the patients, if it is okay with the anesthetist. This helps in keeping the blood pressure and the pulse rate low, so the spongiosal tissue bleeding is significantly less during surgery. Second, we paint the patient after shaving with betadine every 4 hours, 1 day prior to surgery. This is very important. We start IV antibiotics 1 day prior to surgery. We evacuate the bowel, not a very specific bowel preparation, but suppositories are enough in most patients. We have to take this care because patients should not be passing motions after you give the position, because that can be very detrimental to our ultimate results. So after this basic preparation, when the patient is on table, the anesthesia basically requires hypotension. Nowadays, for buccal mucosa, earlier they used to do what is called as intubation, nasal intubation. Now we are doing most of our buccal mucosa harvesting under conscious sedation with the drug called as dexmed, which is very good, very safe. The patient stays in conscious sedation. It allows you to take the graft without undergoing the potential harmful effects of a general anesthesia. So that is for anesthesia. Patient position is simple. It is lithotomy. We do not require any extended lithotomy position at all. After the lithotomy position has given, we pain tape the patient. We do not do any urethroplasty without doing a preliminary scopy in any patient. You have to do a preliminary scopy, even if it is done by some other urologist before the patient comes to you. You have to do the scopy before the person who operates. You have to do that scopy. So the scopy is done by a 6 French uretroscope. This is the best instrument to do scopy in any kind of stricture, let it be traumatic or non-traumatic. You have to do the scopy very gently. If we are able to pass this scope through the stricture in a non-traumatic case, that means your urethroplasty is going to be easy. If you are not able to pass a 6 French scope through the strictured lumen, you have to understand that your urethroplasty can be a bit difficult. How I define the difficult urethroplasty, like how other urologists who are doing endoscopic surgery, they define surgery, for example, a difficult PCNL. I don't know whether you agree to it, but difficult navigation during surgery is a complex case. So in the same way, when you are navigating the urethra through the scope and you find difficulty in navigating, that is going to be a complex case. And if you are not very experienced, you have to ask for help at that time. So the scopy has to be done. It is obligatory in all the patients by a 6 French uretroscope. After you do a scopy, we need to have this particular Nell cath, a Nelliton catheter with a soft rounded tip. Okay, this helps in all the patients because scopy sometimes can not tell us the exact site of the narrowing of urethra. What I do is I insert this Nell cath because it is very flexible, non-traumatic. It does not violate the urethral mucosa at the stricture site. Gently, you need to put this catheter per urethra, and you feel this catheter in the perineum where you are feeling. This is very, very important because most of the time, the scopy reveals that the stricture might be just beyond the penoscrotal junction. But when you put this catheter and it stops in this proximal penile urethra, then you have to change your procedure because in those, probably the stricture is quite distal and your approach might be different. So this is a very
What is the size of this? What is the size of this? You mentioned
this 16? Is a 16 French Nell cath. Okay.
Okay.
So this is a general Nell cath. If the patient is younger, I use 12 or 14, but 16 is usually good. So most of the cases, 16 can work. So you can have only one kind of a catheter. So this is very, very obligatory. You have to have a Nell cath in your OT if you're doing a urethroplasty. It will give you the exact site of narrowing and planning your incision, planning your approach, and potential difficulties which you might have. For example, if this dilator stops in the mid-penile urethra, you cannot do a perineal incision directly because you might require penile imagination or some other penile incision or some other approach to access the penile urethra.
Yes.
Okay, so this helps you plan the incision and the further plan. Okay, after you do that, we inject methylene blue. So methylene blue is injected in all patients before you start the surgery, but after you have put the Nell cath, because you cannot put the Nell cath after you put methylene blue because it smudges the whole incision.
Yeah.
You first have to put the Nell cath, find the site of stricture, and only then inject methylene blue. We don't have to dilute it because dilution will not help. So you take 2 cc's of methylene blue, okay, and through the Foley adapter, insert it gently into the urethra and push some air after that, only 2 cc. And that helps to demarcate the strictured urethra, because this will stick to the diseased urethra. It will not stick to normal urethra where the lumen is lubricated well with the urethral gland. So methylene
this is sterile, na?
This is sterile, yes. It's a sterile ampule. Yeah. Okay, fine. So after you have done this, you plan the incision. The planning of incision is very, very important. When you feel that you are able to complete the urethroplasty very confidently, the incision has to be a midline vertical perineal incision. If you think that the urethroplasty is going to be difficult, or in traumatic cases you might not be able to anastomose, either you seek help or you need to have an inverted lambda incision, where an inverted U incision, so that you can convert this procedure into a stage procedure by doing a perineal urethrostomy. If your incision is vertical and you land up into a problem, your choices are very few. So if you are an early urethroplasty surgeon, or if you think you are going to stop at some time without progressing further, a perineal incision with the inverted U will surely help. After that incision is done, you need retraction. So what I think, I divide the patient into slim, moderate, and obese. The most difficult part is the obese patient, because the perineal muscle and the perineal flat will make your job very, very difficult. In those cases, you have to start applying the retractor in an early stage before you reach the bulbospongiasis muscle. So in those cases, I use this Lone Star retractor. So Lone Star retractor is very good.
Hello, Ashish. Ashish. Ashish, we are not able to hear you. Ashish. Dear friends, this topic which we have kept today is a unexpected topic, and Ashish has accepted for immediate presentation. He is experienced in urethroplasty. Most probably he will join. Yes, he is joining. So yeah, Ashish, you are back. At Ashish, unmute and turn this phone to straight. It is horizontal. Yes, at the Lone Star retractor, from the retractor you have to start, Ashish. Unmute. Yes, sorry.
Okay.
No problem. This type of common problem occurs. A lot of audience joined, even if it is short notice, because it's a hot topic. And
yes,
keep the juniors into consideration. It will be very useful. Yeah.
Okay.
Lone Star retractor. What is the name?
Lone Star. This is the Lone Star retractor. In our Indian scenario, we are not using the disposable one. This is an Indian-made metal Lone Star retractor, which is very useful and helpful in our, especially in obese patients, because this fits well into the perineal fat area, and we can retract all the way you want, and how much of a retraction you want can be done by those silicone detractors which are available here. So these silicone detractors will help you. So these silicone retractors which are there, they are going to help.
They are reusable.
They are reusable. Yes, we can. We cannot autoclave them, but you can ETO them.
ETO, okay.
Yes, so with ETO they can be used, and these are very good retractors because they fit in very well to this retractor, and you have multiple options to fit them, including the upper area of the incision can be extended very well because of this extension, which is not available in the Tenotomy retractor. So this retractor works very well in female patients because I do female urethroplasty also, and also in obese people. So this fits. This is a Lone Star retractor which fits very well. You should be having this urethroplasty retractor if you are doing urethroplasty. The other retractors which normally I use are the Tenotomy ring retractors. Always have two sizes with you because one size sometimes cannot be enough, because in a small, in a thin patient or in a pediatric age group, this retractor becomes a problem because this occupies a lot of space and it does not fit into the perineal area. So you should always be having a pediatric retractor for urethroplasty. Okay. So this is a Tenotomy ring retractor which is used for exposure. Important point is, in fat patients, start applying the retractor early, because if you injure the perineal vessels, the field becomes very bloody and your surgery becomes a headache for you. So avoid that by retracting the perineal fat earlier with these retractors.
That means when you apply earlier, after each stage, like you expose, then you have to readjust these pins
Readjust,
so
yes,
that you can go deeper planes.
Deeper planes easily without injuring the blood vessels.
Yeah, got the point. Otherwise, everything becomes red.
Yeah, another important is the mastoid retractor, which I normally use in the initial stages to retract the perineal fat. So this also can be a very useful instrument in addition to the Tenotomy or Lone Star retractor to retract the perineal fat, especially in obese patients. So you should make maximum use of mastoid because it's a self-retaining retractor, helps you to avoid extra hands into the incision. So after you do,
so apart from applying the Turner Barbic retractor, this mastoid retractor again you apply to the focused area of the urethra.
Absolutely, focused area of the urethra, especially after you incise the bulbospongiosus muscle. Once you incise the bulbospongiosus muscle,
okay,
gently you retract the muscle with the help of the mastoid retractor. So this retractor is very good to expose properly so that you can operate on it.
Okay,
After
right.
you finish doing this, now you are having the urethra in front of you. So now you have the important aspect of urethroplasty is exposure of the stricture site. You need to expose or transect the urethra in traumatic stricture at the right. That is a crux of urethroplasty. If a surgeon fails in exposing the strictured urethra at the right place, probably the surgery might not go well later. So you have to know how to expose the urethra. Again, to expose the urethra, this is the catheter. The nail cath again is a wonderful little thing where we insert this into the urethra. Where it stops, you take a single nick on the urethra over this dilator, over this catheter, so that you do not, you can use a male dilator. But the problem with the male dilator, it skews around, it moves around. So it is not stable. So your incision can become varied. So the best thing is to use a flexible dilator, which otherwise is non-traumatic to the normal urethra. You can take a cut on it and feel the cut while it is happening. So exposure of the urethra is important here. So after you expose the urethra, open the urethra at one point, you have to hold gently the urethra with the proper forceps. Now, this is a forceps which I use. I don't know whether you can see it. This is a forceps.
Yes, very nice to see.
This is a vascular forceps with an angle, which helps the assistant and you to hold the urethra at an angle without the forceps coming into your way. So so this forceps helps you to retract both ways. So you should have two such forceps with you on your trolley, so that even if you're recording the surgery or you're performing the surgery, this angle will always help you to keep your hands quite away and the exposure better. So angle vascular forceps is an important. No use of tooth forceps or plain forceps to hold the spongy tissue. Okay. After you have done that, you need to have a fine scissor, a very fine scissor, which will help you to dissect only that part of the urethra sharply, so that the cut does not go at the wrong area. So after the urethra is exposed, it's opened. You take this pointed scissor over the dilator, you cut the urethra further into the stricture. Okay. So after that, you need to understand that in a non-traumatic stricture, we need to harvest the graft. Normally, people use the mouth dilate, this special instrument, which is used to like a mouth gag and a tongue depressor for exposing the buccal mucosa. I've normally stopped using this because of two reasons. One is, once you put this tongue depressor on the tongue gets pressed and it bulges on the sides of the mouth where you're going to take the graft from. So your graft area becomes covered with the bulging tongue. So I've stopped using this instrument now. So and this instrument specifically requires GA or a nasally intubated patient. So since I've stopped using general anesthesia for the graft and this tongue depressor problem, what I started using is a simple mastoid retractor, self-retaining. What you do is, it is very safe. You have applied this retractor at both the teeth, the upper teeth and the lower teeth, and just open the mouth with this. What happens with this retractor is, the moment you apply this retractor, the tongue falls back. Once the tongue falls back, because opening the mouth, you have a good area and a good exposure of the buccal area to take the graft.
That won't cause problem in breathing?
It does not cause problem with breathing because the patient under conscious sedation is awake. If you apply dexmedetomidine, the patient is awake and he's breathing and he's obeying our commands and he has an amnesia for that particular time. So that is a wonderful way of getting the graft. It is called as conscious sedation.
Okay, very good.
Okay.
It's a new point we are learning.
Yes. So in that patient obeys all your commands. If you tell him to open your mouth, he'll open your mouth. If you tell him to turn, he will turn. If you tell him to breathe, he will breathe. So it's a wonderful drug wherein where the patient is very cooperative and we avoid complications of general anesthesia. That was a point for. Second point, now what we use is again a pointed scissor for the graft. If you do not have this scissor, this pointed scissor, we should not be taking the graft, because the crux of having a good graft is less amount of muscle and fat and more amount of epithelial tissue. That is only possible by using a pointed sharp scissor. So this is an ultimate necessity while taking the graft. If you don't have this, you end up in taking a lot of muscle along with the graft, which is the root cause of further complications for donor site areas like mouth shortening, more amount of fibrosis, injury to the salivary duct. All these problems will occur if you take more muscle along with the graft. So avoid any donor site complications, reduced mouth opening. You have to have a special kind of a scissor which will help you in getting less muscle and only the graft.
And do you take stay stitches in the and lift it and
yes,
then
so
cut with scissor?
Stay stitches with ethylon, because we normally don't use any linen or any silk, because it can form a scar on the lip. So we use 2,0 ethylon or a 3,0 ethylon to take stay sutures. We need to be careful that when you're taking the stay sutures on the buccal, for the buccal mucosa, the stitches should not be on the outer edge of the mouth, because in some people, that single stitch also, the stay stitch can give a very bad scar. So all the stitches have to be on the inner side of the mouth and not on the outer side. So we have to be a bit careful, especially when I'm doing female urethroplasty in young women. Sometimes you have to take that special precaution that your needle should not go on the exposed area of the face, because that can have a bad scar and which can be completely permanent. So that was regarding buccal mucosa. Okay, important point in buccal mucosa is you always have to have a small gauze at the edge, at the angle of the mandible, so that whatever blood soakage is there is absorbed by the gauze, and you take out the gauze after you finish the graft. That will prevent trickling of blood into the respiratory area. Okay, so that is very important.
Do you close the graft or do you keep it open?
I always keep it open. There is no need to keep the graft stitch the graft at all, because whenever we have started stitching the graft, patient has a lot of problems with mouth opening, lot of pain, and the problems of salivary duct occlusion and injury are more when you suture it. Because
and what bipolar coagulation you use for the bleeder?
Yes, I use bipolar coagulation. As far as possible, if you are using the right scissor, you don't need any coagulation. If you use the major bleeding points in a buccal mucosa graft is the lower labial vein and the artery. If you are able to preserve those labial veins and arteries well, upper and lower, you normally don't need any cautery at all. So avoid using the cautery, because the moment you take the graft out, you have the buccinator muscle. The more you coagulate that muscle, the more it is going to contract and give more pain to the patient. The patient won't be able to do mouth opening exercise at least for 5 days, and that is the time when the contracture will happen. So please avoid using cautery at all. So I use very minimum cautery unless and until there is an arterial bleeder. Venous bleeders don't need any cautery. They can just be taken care with local pressure hemostasis.
Do you hold the graft with the hand? Sometimes people hold with the hand and thumb and keep on dissecting towards the proximal end or distal end, whatever. Or you will use nylon threads to pull the graft.
No, you are not supposed to use it because the graft is very slippery.
Yeah.
Every time you are holding the graft with your finger, it is going to slip down. So it is better to use stay sutures, 2 ethylene sutures at the edge of the graft to. Harvesting of a graft is a completely different topic. Sometimes we'll talk about it also.
Yeah, I got the
because
point.
I've introduced some new techniques for graft removal.
That we will discuss. No problem.
Fine. So, yes. After you take the graft out, what you don't need any special technique for thinning the graft. If you use the proper scissor, you can use the graft right away. Just take out the excess fat on the graft, and the graft is ready to go. We dip the graft in amikacin solution. You add 2 ampules of amikacin, 500 each, 1 gram of amikacin in the normal saline. Keep the graft immersed in that particular solution and use the graft whenever it is required. So we come back down at the perineum again. We have the open urethra with the stricture which is open, and we need to now expose the urethra well so that the graft fits well. For that, you again require 20 ethylene sutures, which are very important again, because exposing the urethra properly will help you to know where the edge of the mucosa is. What happens is, when you are doing the surgery and when you expose the urethra, you need to understand that when you take the stitch, it should not go through and through the whole thickness of the spongiosum, because it is going to compromise on the spongiosal blood supply. Your mucosal stitch of the buccal mucosa should exactly match the stitch going through the urethral mucosa and not the spongiosa. For that, you need this retraction, which is important.
So your stay stitches are always ethylene.
Always ethylene, always ethylene.
It is less traumatic because it is
ethylene is easier to mono.
Monofilament and very commonly used. Okay.
Absolutely. And we need to have this lighter artery forceps or the mosquitoes. Because what happens is, if you're using the heavier ones, they will usually fall down with the weight. So the lighter, very small ones, if you see this mosquito, I'll show you on my hand, it's a very small mosquito.
Yes.
Okay,
yes.
a very small mosquito which is available, smaller than the normal mosquito size. And these are very lightweight and they help you in retracting the urethra very gently. If you're using the bigger artery forceps, they will tend to pull excessively, and there more injury is going to happen to the urethra and your anatomy is going to get distorted. So use these lightweight, smaller mosquito artery forceps. Okay.
Yes.
Now, after you open the urethra, to feel the proximal end, it is very important that you open the urethra adequately. So after you open the urethra, you need to sound the urethra with the dilator. Here you can use the metal dilator. Now this dilator is 11 by 14, which is good enough for all cases. You don't need any dilator bigger than this. If this goes in very easily, you have opened the urethra well. Now what happens?
Why not Nelaton catheter only? Why not Nelaton? Because this
You
may
can-
dilate in a slightly shorter, short segment stricture if Nelaton
Yes.
cannot pass now.
Yes, Nelaton also is a good dilator, but the problem is this will follow the bladder curve better because you can feel the urethra going through it. In the Nelaton, probably, since you're putting it straight inside, sometimes you don't know how
Resistance.
the dilator is passing.
Okay.
So this will help you to navigate through the bladder neck properly. So this is
Okay.
better as far as proximal sounding is concerned. So this is the male dilator. After you have done that, what you have the picture is that you have the proximal urethral end from where the urine is coming down. Now this urine drainage is a trouble sometimes because to take the stitch, this urine is coming out. So what I do here is I put the nasal speculum. So you need to have this speculum handy. So this is the nasal speculum, a self-retaining nasal speculum. So this speculum, if you see, has a screw here. With this, it stays inside. So what happens is the moment you put this nasal speculum for 3 to 4 minutes, your bladder becomes completely empty because it is surpassing both the external sphincter as well as the bladder neck, and the bladder becomes empty. Your field becomes completely dry. So this is an important instrument to be had on a urethroplasty tray. Okay. After you do that, you are ready to suture the graft at the proximal end. Now, this is the most challenging part where you suture the graft. If you see the two ends, A and B, A is the proximal end, B is the distal end. So suturing the end A of the graft to the normal urethra proximally is the most challenging aspect.
Yes.
And what I would call the future of urethroplasty result. So if you are not able to do this properly, probably urethroplasty is going to be a failure. So for that purpose, you need proper exposure. Again, this instrument, the nasal speculum, is very good because it will help you to retract that urethra, the bladder, the external sphincter also, so that your exposure becomes very good. It has already drained the bladder, the field is dry, and what you need is the suction, the metallic suction which we normally use. We do not need a very thick suction. We need a very thin ENT suction, which is very good. And we need to understand that we should be hydrating this small hole air valve which is there, because the moment you obliterate this, it is going to suck the graft along with it. So remember, when you are using the suction in urethroplasty, it has to be a metallic suction. It has to be a small bore suction, and the air valve needs to be open so that it does not suck the graft. So this is a very important practical point, because every time you take a stitch and your assistant comes and sucks the graft and the graft snaps out, you are going to have a lot of problems. Okay, it is very irritating. So you need to understand the kind of suction which you need to have. Now, the most important thing is the suture. What suture do we use for urethroplasty? I have used various sutures in my 10 years of my experience of urethroplasty. I have finished more than about 1,200 urethroplasties now. What I have realized is what we need is, number one, an absorbable suture. Okay, you need a very suitable needle which can be maneuvered very well into the urethral lumen. Number three, we need a suture which does not stay in the body for a longer time, because if it stays in the body for a longer time, it is having a potential for other problems. Number four, very important, is handling during the surgery. So all these were very well met. I use Vicryl. I've used other sutures also. But the best suture what I have come out with is the 40 monocryl. The 40 monocryl, code number 1205. This is an absorbable material. Okay. The needle is very good. It is 16 mm, 3/8 of the circle reverse cutting needle. So this is a very apt needle to maneuver for all kinds of urethroplasty. This is a monofilament absorbable suture. So the advantage here is we are getting away with the braided ones, avoiding infection, avoiding tagging of the graft along with the suture. So most of the time what you see is you take the suture, the graft will come along with the suture, it will be stretched. Okay, because it gets entangled in the suture. So this, since being a monofilament suture, the thread will flow easily through the graft and through the mucosa. And it is absorbable suture. So monocryl which is monofilament polygalactopone 1205. So this is the suture of my choice for buccal mucosa urethroplasty. I repeat, only for buccal urethroplasty. For traumatic strictures like pelvic fracture or for end-to-end urethroplasties, we use the Vicryl 2443. This is also a very good suture for urethroplasty, especially for anastomotic ones. Okay, and this comes with the Ethiprime needle, 16 mm again, 3/8 of the circle cutting. So this is a suture for if you want some strength to the anastomosis. So this is the suture. So these are the only two sutures which are normally used for urethroplastics. It is monocryl 40 and Vicryl 40, 1205 and 2443. So once you have the suture in your hand, which is the monocryl, you need a needle holder which has a flat tip or a narrow tip. So if you compare the needle holders, these are two needle holders.
Yes.
Okay. So this tip, if you see, is a narrow tip, and this is a fat tip. We don't want needle holders with fat tip. We want needle holders with a narrow tip so that we are able to see and maneuver the needle in that urethral lumen when you are specially attaching the end of the urethra to the graft. So we need something which is very thin and narrow and longer. So if you see, this needle holder is longer. We don't want a shorter needle holder because your hand is going to come into your way when you're suturing. So if you see this, the hand comes into the way. But if you have a longer needle holder, you have the tip which is seen very easily. So have a longer needle holder when you're doing the proximal urethral anastomosis. We again have a special kind of a needle holder, which is a curved needle. I don't know whether you can see it. This is a curved needle.
Yes, we can see.
So this is a curve. What the specialty is, it has a curve at its distal end. So this curve will help you to see the needle, because now what happens is that because of this curve, the needle is deflected on one side. You're taking the suture. At the same time, the needle is seen and the urethral lumen is seen. So this curved needle holder is a very helpful needle holder for complex cases. So you should have this needle holder along with you. After you have done this, again, the anastomosis is done. We use a 16 French. Normally, in all cases, I use a 16 French silicone catheter for most of our cases, which is kept for 3 weeks. I don't keep it for a month. In all cases, we keep for 3 weeks because I think 3 weeks is a good enough time for any good surgery to heal. So we do not keep catheter for a longer time because probably I think it does not help. In cases after we take out the catheter, either there is a small fistula or there is a problem to the patient, only then we reinsert catheter and keep it for a week. But 95% of cases, we keep a catheter for 3 weeks only.
You don't do pericatheter RGO or widening MCUG like that?
The only best test which I follow as a result of urethroplasty to analyze the result is uroflowmetry and the patient's score. If the patient tells you that he is voiding fine, the flow is good. It is documented on uroflowmetry, the flow is beyond 15 mL per second, your urethroplasty is good. You don't need any other investigation to prove your result. Unless and until the patient, for example, if a patient of pelvic fracture is operated by you, you take out the catheter, patient passes urine well, the flow is good. Patient comes to you back after 3 months telling you that the flow is poor. That is the time you need to do a imaging procedure. Because an imaging procedure which is required immediately after surgery is useless because it will not give you a proper picture immediately after catheter removal.
Yes.
If you want a good picture, it is usually after 4 weeks that the stricture is going to reform. If your urethroplasty is failed, it is going to look properly on the imaging. So I do not recommend doing any pericatheter study or immediate invasive study at all after you do any kind of urethroplasty, unless and until there is a problem. So please do not do any RGU or scopy after the catheter removal.
Very good.
So these were important things. Important things are in traumatic stricture. You need to understand one thing, a very important thing, that please seek help. Traumatic strictures are not easy. please have an assistant with you who is experienced enough to tell you what are we going to do if you land up into a problem. The most important aspect of traumatic urethroplasty is finding the proximal urethral end. That is where the complexity starts. If you are not able to find the proximal urethral end in a traumatic case, either we need to seek help or you just wait before you do any further damage. To find the proximal end, most of the times we require inferior pubectomy. So this is a very good. This is a hammer, and this is a very good chisel which we use. It's a very lightweight, okay, and very sharp edges for inferior pubectomy. You need to only have 2 sizes. You don't need any sizes more than these, okay. So these are very 2 good sizes which you get. One medium and one small, and they are with wooden handles with a metal head. So they are very good so that when you are hitting on them, there is an angle to them. You don't need a straight chisel. If there is an angle, this angle helps you because when you are taking out the bone chip, you are able to see it well across. So when you're hitting it, the bone chip is seen coming out. You don't need a straight chisel to have. Okay. This is one important instrument which I had designed. I had asked one person to make, where this is a Teal Speculum, wherein I had incorporated the suction. There is a suction. Okay. The suction is attached to this retractor, and there are small holes into this retractor. If you see, so what is the one good thing about this is the moment the blood trickles here, it will get immediately sucked, keeping your vision good. So I'm still in making, there are some issues here in this, but I'm still in the process of more refining this retractor. So this is a suction enabled speculum, urethral speculum.
Very good. Okay.
Another important thing what you require is a Hagrove's retrograde antigrade bougie. So this bougie has to be there in your urethroplasty tray for 2 reasons. One, when you are not, as I told you, the most important difficulty in urethroplasty is navigating the urethra. So this instrument helps you navigate the urethra in an antigrade manner through the suprapubic catheter. So there is a proper way to put it. You need to insert it straight like this, unless until you feel the giveaway resistance in the bladder, and then you turn it very gently and you feel the lumen. When you are using this, you are not supposed to use any manual force at all. The bougie needs to walk through a normal tickling force. You don't apply any manual force. The moment you apply manual force to this instrument, you are going to end up into a false passage into the bladder and a wrong anastomosis. What happens, since this bougie is curved, the pressure transmitted at this end is not equal to what you feel here. So most of the times when you're manipulating at this end is going haywire as compared to another retractor. Suppose this retractor, you know the pressure transmitted, how it is going. In this, when you are transmitting pressure here like this pressure is reverse. It is not in the same direction. So most of the times when you are using this, you go wrong in applying the pressure. So please do not use any force to navigate this Hagrove's bougie. That is an important message here, because the moment you try to do this and put it inside, this tip is going to go in the wrong direction. So it needs to just hold with 2 fingers and you have to just slide it at the place where it hits and slowly manipulate to the lumen. That's it. So Hagrove bougie is an important part. Other scissors which are important are the metronome scissor. You should have this scissor with you for all major dissections. You need to have a pointed scissor for the urethra and the buccal mucosa. Okay.
Yeah.
You need to have a strong scissor, a strong curved scissor for taking out the fibrous tissue in traumatic strictures and to cut the scarred portions of the urethra. So this is an important scissor which you need to have. In hypospadias and other kinds of reconstruction, you need, or penile surgery, you need these two scissors, the pointed one, that what is called as the Tenotomy Scissor or the Tympanectomy Scissor, Tympanoplasty Scissor. So these two scissors are very important, especially when you are raising the neurovascular bundle of the penis. So you have to have, without this, you cannot do delicate surgeries, especially the hypospadias and penile reconstructions or chordic corrections. So these fine scissors are obligatory. After one important thing which is
you do quilting also with monocryl.
Yes, the monocryl is the best suture. I do the whole surgery with non-traumatic stricture. I complete the whole surgery with monocryl. Even the skin I close with monocryl. The quilting is also done with monocryl, and urethral closure and spongioplasty is also done with monocryl. So monocryl is a very good suture, slightly expensive but worth it. You need to have this Foley adapter to put the methylene blue and jelly. Please don't use a syringe because it does not help. So this adapter is very, very important. You have to have this adapter in your trolley always.
In ventral onlay urethroplasty, when spongiosum is bleeding,
yes.
What are the stitches and what is the normally we don't do eversion like in dorsal. If you do completely eversion, then you cannot put the graft to the edges. So two things I want to ask. Continuous bleeding will be there, which appears a little disturbing. And second thing is, can you apply X type of stitches in the bleeders with any? For that also you use monocryl?
Sir, you have asked a very, very, very good question. This is a question which is faced by most of the people. What I will say here is that as like a married man gets used to his wife over the years, slowly, a urethroplasty surgeon needs to get used to the bleeding spongiosa during his surgery, because spongiosal tissue is a spongy tissue. It is the only source of blood to the urethra. For our convenience, we should not be cauterizing, stitching, or holding this bleeder anywhere.
Okay.
That's the reason. That's the best thing. What I do is retract. The moment you retract with a gentle mastoid retractor or a single stitch, which is not knotted, a single stitch through and through, you take and you just, with the small mosquito like this one, you just attach it on the side. Your bleeding is going to be controlled. But do not take any knotted stitch on the spongiosa. No coagulation on the spongiosa, because the spongiosa, if you start coagulating, at one point it will stop, it will bleed from the other end, because it's a spongy tissue. So we should not be doing any coagulation or stitching for our convenience on the spongiosa. The pathology of stricture is spongiofibrosis. By taking sutures and coagulating the spongia, you are creating more spongiofibrosis. So please do not do. A wonderful question though, sir. It's very important and very practical.
Okay. So in ventral onlay, when you take the bite, especially in proximal, some people say that in laparoscopy ski needle, where you bend the needle like in a ski type, do you require so that you pass vertically down in the lumen? The major problem is when you are taking it out, it touches the floor of the mucosa. It irritates. Can you comment on what needle and how is the curvature of the needle is important, or your monocryl, what you have shown? That curvature of the monocryl is not that much. It's only size, I don't know.
See, the needle, what I would suggest here is the needle, sometimes you can bend the needle to a certain angle in some cases. But normally what I do is, if you are using the right needle holder, for example, this is the needle.
Okay.
What I do is, rather than holding the needle at the edge of the needle holder like this, so this gives you a very acute angle of the needle with the needle holder. So what I do is, you hold the needle more in the midline, let the needle go more inside the needle holder. The moment you do this, your angle is changed. Can you see it?
Yeah.
So if you see this angle where the needle is pointed upwards, So this angle, the needle is pointed upwards, right?
Hmm.
So the moment you take the needle holder more ahead, you will see automatically that the needle is straightened now.
Okay.
So this is more better rather than bending the needle to take the stitch. So if you have lesser amount of needle exposed outside the needle holder, your stitch is going to be easier. That's what in some cases, yes, you can do this where you can hold this needle, and what I do is a slight push downwards. So this makes it the ski. So it makes an easier. But what happens with this is you are increasing the distance of the needle holder to the tip of the needle. So what happens is that when you put the needle inside, this tip of the needle goes far beyond inside, which is unreachable for you to retrieve it back. So sometimes you have to retrieve it blindly. So rather than doing this, what I would suggest is holding the needle more close so that your stitch is under your control. The tip is seen and you can retrieve the tip very easily. Good question, sir. Very good question.
Yeah. And one more thing, when you take the bite, commonly people say 2 ring strictures form on either side. Of course, it's a technical point because we are discussing the instruments. When you take, nowadays in pyeloplasty, people are not taking 12 and 6. They are telling 1 and 11, 5 and 7, so that the lip of the mucosa is not sutured to the angle. Do you follow that? And any outside in or inside out from the urethral side, this type of needle, because the urethra of the distal, you can easily see there is no problem. It will be in the air, or graft will be in the air. Only problem is first 3 stitches of the apex of the proximal urethral cut edge, where some bleeding, some urine, as you said, speculum will help a lot. That is a good point taken. And what is the point you wanted to tell to take the first 3 stitches at the apex?
So the first, what I think is the most important stitch is the stitch which you take first. The 6 o'clock stitch is the most important stitch. If you take that stitch well, the other stitches are easy to take, and I will just show you how do I do it. Give me a moment.
Yeah, no problem. You are really practical, and you are using simple phone to explain this. Highly appreciated. No modern gadgets. For the juniors, this is very ultimate idea of this program. Pure is mainly focused on the juniors who are interested in urethroplasty. If they are not exposed in there, seniors anyway will do it. It is a matter of first 2-3 years of private practice or final year residents. Good. Thank you very much, Ashish.
So if you see, this is the urethral lumen, right, where you're going to stitch the graft. Okay. So you take the cut on this graft, which is like this. You don't have a complete circumferential lumen. So what you do is you take this raw cut here. The graft is going to come in this area. So if you have a graft which is rectangular like this, as you rightly said, if you stitch this and make it round, it is going to form a ring. So rather than doing that, you cut the graft in this shape. So this is your final graft, which is tapered. You stitch this part of the graft here, take the needle out from here and stitch the graft here. So the graft now comes here. So this is the way you avoid making a circular ring. So this is the trick. So you always suture the graft in a rooftop manner. Never suture the graft in a straight manner. This is how we prevent developing a circle. Now, once you take this stitch, okay, the other stitches are very easy because now you see this edge of the graft where you can take the stitch here and this stitch here. And I would suggest do not cut the stitch here. Retain this long end of the stitch here so that you can continue stitching this graft to the urethra and this edge of the graft. What most of us do is take this stitch and disconnect both the ends of the suture. So what you do is cut the short end, keep the needle end long, and continue suturing this graft to the edge of the urethra.
Okay. When you suture the graft to the urethral edge, there are two schools. One is anyway graft has to be taken full thickness. Graft is very small. When you take the urethra, people say 1.1 millimeter you leave the mucosa and take just below the mucosa so that edge to edge approximation will come, especially in continuous. It looks beautiful, they say. Second thing is full the breadth in plastic surgery, they take minimal. If you take too much breadth, it causes a crumpling effect. Any comment on that?
Yes, very good question again, sir. See, when you are taking the graft, it is very simple. You don't take too much of the thickness of the graft. The graft, buccal mucosa graft, is a very resilient graft. It does not require a lot of strength to be there. What it needs, as you rightly said, is proper approximation. For approximation, you just need to take the edge of the graft within a millimeter, the stitch in the graft. And as far as the urethra is concerned, again, it's a very thin mucosa. You don't need a very big bite into the spongiosum at all. So the stitch has to be graft to mucosa. That's it. We don't take any thicker additional tissue at all, because we need to understand that this stitch is only for approximation, probably for 3 to 4 days. After 3 to 4 days, no matter what you apply, it is not going to be useful at all unless and until the approximation is right. So we need to concentrate not on strength here. We need to understand the geometry and the approximation. So if the approximation is good, any suture which holds the approximation for 3 to 4 days is good enough to give a wonderful result.
Good that the Sanjay Kulkarni sir has joined. I requested him in the morning.
Hello, sir.
Yes. And Harshavardhan Tanwar, Harshavardhan Tanwar sir, Harshavardhan Tanwar is asked, do you have any role of SPC? Actually, when you are telling that round semicircle retractor, when it goes into the lumen through the SPC, now in the present era, we are using endoscopy to negotiate the bladder neck. We are using flexible scope to negotiate. You wanted to add on that because there are 2 points. One is mature tract of the SPC if present, that is a different issue. If on table, you said that proximal urethra cannot be detected. For example, somebody has transected, after that not able to see any lumen, finding, scopy, guide wire, nothing has passed. So if you pass the guide wire first in the beginning, is it good? Number one, especially if the 6 French ureteroscopy is not going, which you said is difficult case. Number two, if you wanted to do open cystotomy, what are the instruments and how you do it? Number three, does your when you open the bladder and do the access from above to make it successful procedure in traumatic, what are the problems? Sometimes in obese patient, entering into the bladder itself is difficult. So I know these are all basic questions. Keeping the juniors into view, comment on these.
Okay, another very important point here, sir. What do you do if you require an antegrade access to the bladder in absence of SPC? So nowadays, what we get is a peel-away suprapubic catheter. The best part of this, it has 2 plastic things. One is which is attached, it's a peel-away sheet which is disposable, and a trocar which is of plastic. Okay, so
yes,
what you do is you just put an on-site SPC trocar cannula into the bladder after filling it. You take away the trocar and the cannula, which is a peel-away cannula, without peeling it away, just keep it inside. That will give you direct access into the bladder for a 6 French ureteroscopy to pass. Okay. If you do not have a peel-away cannula,
yes.
So what we do is we just put a bladder, dilate it into 2 or 3 dilator sets, and put an access sheet and have an access. Even if you are not having that, the best thing what we can do is to put a 10 mm trocar of laparoscopy, which is a valve trocar. The moment you fill the bladder, take an incision, put this trocar inside, and you can have a good access to the bladder. But the problem with these is that you can only maximally use flexible scopes through them. Passage of a rigid scope through these sometimes can be a bit difficult, or bougie. If you want to pass a Higro's bougie through this, it's not possible. Yeah. So you need to have flexible scope ready when you're doing a temporary SPC. As far as
so actually this, I think flexible nephroscope is a small contribution in this era actually. So Dr. Kulkarni sir also says that, and you are also emphasizing, if you put a rigid any metal or any outer sheath, negotiating the especially if it is more close towards the bladder neck, it is very difficult. If you are little away, just below the umbilicus in a very distended bladder, oblique tract, probably you can go up to the veru and maybe pass a guide wire in difficult case and then follow that guide wire from below.
Yes, very right. Yes.
Yeah.
As far as your question, which was there of opening the bladder or doing an open cystotomy, I had very few experiences where I have to actually open the bladder to complete the urethral reconstruction, unless and until I'm doing a fistula or other complex surgery. But usually, we do not require to do an open cystotomy when you are doing a urethral reconstructive procedure. As far as pre-operative suprapubic catheter is concerned, yes, I nowadays have found a lot of utilization of putting a suprapubic catheter, especially in our country, because most of the people present to us after they have a complication like retention or infection. So in these circumstances, to do a urethroplasty, I think is not right, because there is a presence of infection. The graft is going to be eaten away very fast, and there is a lot of scarring which is going to happen if you do it in an infective stage. Second, when patients come into a chronically obstructed state and the bladder becomes too distended and hypocontractile, usually these patients are not going to have a satisfactory result after you do a urethroplasty. It is just like doing a TURP in a chronically retained hypocontractile bladder, where you might anticipate need of prolonged catheter after surgery. So you have a choice: either put a catheter before for 2-3 weeks till the bladder stabilizes, or to keep the catheter 2-3 weeks after the surgery. But I prefer in my cases to keep a suprapubic catheter before surgery in chronically obstructed patients and where you anticipate infection, so that your urethroplasty is more smoother as compared to those cases where the SPC is not good.
And one more question: when the SPC is kept, for example, if you are having ureteric stricture, if you do nephrostomy, stricture will close and you will not find the lumen. The same thing can happen in even inflammatory strictures. The mucosa may close and the stricture may worsen, and it is called stabilization of the stricture. Ideally, giving rest and giving stabilization for 3 weeks is good. But why many people, even including seniors, does not apply? For example, in our place, Dr. Ramaraj sir does. He says any patient who comes with pain, fever, no question of doing within 2 days or 3 days, put SPC and send for 1 month. Even colonization, there is no problem. 1 month you rest. By that time, entire logistics of RGU and MCG will change. This is actually subject different, not related to instruments. We are talking about SPC. I will just come to the point. Before that, Sanjay Kulkarni sir told role of Turner Barbic needle holder for posterior rethroplasty. Do you think it is good?
Yes, I am not using it because I don't have the needle holder, frankly speaking. Probably sir would be able to better tell us about the Turner Barbic needle holder. But it is a very good needle holder with a specific curve, which helps us to access those kinds of cases where the urethral lumen is too deep. So that Turner Barbic needle holder, but I don't know where it is available, because I have not found it very easily available in our conferences or when we buy the instruments.
Actually, this is also point all the instrument which you have shown, they will be available with local surgical like RK Medical or any person. They are available, I think.
They are available. Yes, they are available.
All the instrument which you have shown. Even the first retractor round 1 is available with our local vendors.
Always. I personally, if you ask my preference, Wilson and Wilson makes perfect, very good instruments, and I really prefer their instruments.
Yeah. So another thing is, sir commented on C sheath and Pepsi straw. This is actually used in PCNL also, where outer metal C will be there. Even in urethra, it is used. Even in PCN, it is used, so that you can insert through the C shape, and you can take out the outer one. Straw may be too thin for the rigid endoscope. If it is flexible, you can use it. Sometimes getting bladder.
Yeah.
Sometimes getting bladder neck is very difficult, Ashish.
Yes.
Sometimes without scope, with dilator, junior can disastrous injury to the bladder neck, which should not be done, as you said in the beginning, which should not to go close to the bladder neck. Bladder neck, I think, is very important in urethroplasty. So blind bougie days may go, and the nephroscopy and the ureteroscopy may come into picture. What do you think?
Yes, you're right. Flexible instruments are far more better than doing blind instrumentation. So as you rightly said, if I have a choice, I would rather use a flexible ureteroscope or a cystoscope to navigate through the bladder neck. Because what happens is, especially in older patients who have maybe a median lobe, or they have a larger prostate which is indenting into the bladder, finding the bladder neck through blind instrumentation sometimes can be very hazardous. Therefore, I told you, especially when using the hygroves, you have to be very gentle and let the bougie find its path rather than you finding it for it.
Yeah. Anything more, Ashish? You have covered all the instruments. Actually, this is a sudden at 3 o'clock. I have decided, because for one reason, when I have put in the morning, anybody who want to discuss urethroplasty instrument, nobody started, because I am not that much knowledgeable. Yesterday, when we discussed about lasers, lot of nearly 25 people discussed. I was able to answer some of them, and you could quickly come into the picture and told most of the things. I must really thank. One last couple of questions I want to ask you. When you use the monocryl, when you do cystoscopy, generally when you do cystoscopy in VVF repair, vicryl will be seen after 4 weeks also, like a thread. We don't feel comfortable. Still, it will be healing. Do you think the monocryl will fall off? Monocryl will fall off earlier than vicryl? It's a too much depth question. A pathologist and a very knowledgeable person can answer. I'm just casually asking. When you do urethroscopy, these stitches you said should fall after 1 month. They don't have any purpose after 1 month.
Yes. But vicryl probably stays for a very long time. So the braided vicryl. Monocryl, this monocryl 40, what I used to use the 50 monocryl in circumcision, actually, to close circumcision wounds. In there, what I found was the longest suture which stays there is the vicryl. After that, it is monocryl. After that, it is catgut. And after that, it is vicryl rapid, which you get nowadays.
Yeah.
So the vicryl rapid is the best suture for circumcision, because you don't need the suture for a very long time. Most of the patients will tell you that this suture is troubling them even after a month. So nowadays, since I started using the vicryl rapid, it is a very soft suture which gets dissolved very fast and falls off very fast as compared to any other kind of suture. So, as you rightly said,
one more step now. What I am observing in laparoscopy is PDS is so good. My God, in handling, the main difference between PDS and monocryl is a cutting suture. When you take bite, by chance, if you pull, by chance, if accidentally, if somebody pulls, it cuts through because it makes a small hole. I mean, this is my feeling. You are enjoying it because it is 40, whereas the PDS is absolutely pointed round body needle. Absolute point. I mean, you really feel where you want to come out, it will come out, except in thick tissues.
Yes.
So future may go towards PDS. Yeah.
Yes. What, as I rightly told, see, whenever you want to need strength for a longer time, PDS is a very good suture. It's a very strong suture. When I was working with Professor Radosh, and I asked him why isn't he using PDF, what he used to say is, I am doing reconstructive surgery on the surface. Okay, I don't need suture for strength. If I use PDS, it is going to stay for more than 2 months or maybe 1.5 months, and there is quite likelihood that there can be a superadded infection and damage to repair if the suture stays there for a very long time. So on surface surgery where you don't need strength for a longer time, I would not prefer PDS. In those cases, vicryl or monocryl is a very good option.
And one more, not outside, not inside, not a major thing. Last question, not outside versus not inside, because you people are going into the too much depth to give the best results. We may
Yes.
not understand, because if I talk about flexible ureteroscopy, definitely I know what is the acute angle in the kidney and what are the small cells like that. You people are going to minute levels, not outside versus not inside. What is your comment in any
The
suture?
not, I really don't think there is any difference in that. But what I've learned from Dr. Kulkarni also, that the knot needs to be in the lumen so that it falls off early rather than it staying into the tissue planes for causing more fibrosis. So I agree with his teachings that yes, the knot has to be in the lumen so that it does its job and falls off with the urine rather than staying into the body for a longer time.
Even in laparoscopy, pyeloplasty, when sometimes juniors, when they are doing, not inside is easy. So so we do it inside, nothing happens. The stone will not form in such short time. So
Absolutely.
this is an excellent discussion today, Dr. Ashish, especially Dr. Kulkarni sir also joining, and you have enlightened everything. The best part is you used a cell phone, I think, and you have kept all the instruments within 1.5 hours of my request. And this YouTube link will be there. And for all the juniors, it will be very useful. All the scissors. We think that we all go to stalls. We will be thinking which scissor to buy. Sometimes the diamond shaped tip scissor, what you have shown for the buccal mucosa, may be useful. And another point is speculum, which nowadays everybody is using. This becomes established method of doing the procedure for all the juniors, so that the results will be better. And definitely this program is useful for many. And for all the audience, this 10 days, we are doing slightly less number of programs, because Urology Society of India is upcoming presentations are there. So we are reducing the pure program this 10 days. So please participate in the discussion in the group. We will discuss daily on small common things. Kindly seniors and juniors exchange the knowledge, so that it will be useful and we will be active. So once again, I appreciate and thank Dr. Ashish for participating in the pure, and I wish you all the best.
Thank you, sir, so much. It was an honor. Thank